Hello, my name is Zach Wicks, and I'm in the Masters of Science program for Biomechanics at the University of Kentucky. And today I'm going to be presenting on testing of the Martin Bionics socketless socket for amputee gait kinematics and other hopeful health benefits. I also would like to apologize in advance. Having to transfer this back and forth between PowerPoint and a Mac, so some of the formatting is a little bit off, but I will be submitting that online in a cleaner format. So let's get right into it. Successful and correct ambulation in our amputee population is key for maintaining their future health. Prosthetics have been evolving over the last 150 years, going all the way from a hand-carved wooden leg by James Hanger all the way to these carbon fiber energy restoring running blades that are, in this picture, they're used by Oscar Pistorius, who was notoriously disqualified for having an unfair advantage in a race. Now, the traditional method for affixing a prosthesis to a person is a socket. And you can see here what they're doing is they're doing a casting of the residual limb. And with this, prosthetics they're designed to weight bear on soft tissues. But the problem is that soft tissues aren't meant for weight bearing. I'm gonna also have to kind of step up. Sorry. Now, one of the key designs to this is to make sure that the socket is tight enough that it doesn't slip off, but also that it's loose enough that it doesn't quite restrict circulation, which is something we're going to be talking a lot about here. But with that tightness and looseness, that fit there, we have this common problem called pistoning. And pistoning is just the vertical movement within a socket. And one of the biggest problem to this is it causes ulcers and blisters. It makes it just generally uncomfortable to wear a prosthesis. And the idea of having a prosthetic is so that the subject can get up and walk around and maintain a healthy lifestyle where, you know, the normal afflictions that come in on somebody who leads a sedentary lifestyle, those kind of get forced upon an amputee as well if their prosthetic doesn't fit quite right. One of the problems, though, we actually don't have an effective method for testing pistoning, at least in movement. There have been tests where, you know, they've done x-rays and they've used all sorts of other different measurement techniques, but we haven't found a way to properly measure it during walking. There have been a few close ones, and I think I've got a decent idea here when it comes to my thesis. And the only reason I'm properly testing this is because, you know, the subjects are going to be in the lab anyways. It's not going to take any extra time on my part. But as I was kind of mentioning with sedentary lifestyles, cardiovascular disease, with it being on the rise and also with the rise of diabetes, we are seeing more amputations, which are coming from some of these comorbidities. In a study by Dillingham, they reviewed Medicare patients that underwent amputation due to dysvascular issues and found that 26% of these patients that underwent an amputation due to a dysvascular issue required a further amputation within 12 months. And more disheartening, 33% of those amputees died. According to a study by Sanders and Fatone, the human body requires roughly 4 to 6 months in order to be considered a mature limb in an amputee, at which points they can actually begin, hopefully, ambulating on a prosthesis. One of the problems is that there's a lot of fluid volume fluctuation just from day-to-day living. And these sockets take a little while to make. So in other studies, it's shown that physical activity will stimulate better vascular remodeling. So if an amputee can get up and walk around more on a correct fitting prosthesis, they have, in theory, a lesser chance of a further reamputation. Because one of the big things is that amputee limb length is a very strong factor when providing chances for good and correct gait. So the shorter the limb, they don't, it's a lot less of a chance than if somebody's just missing their foot. Near-infrared spectroscopy is a way that we'll actually be able to measure the blood flow. What an IRS does is it is able to scan between 750 and 950 nanometers of near-infrared light, and with the technology in place, it's able to distinguish between oxygenated and deoxygenated hemoglobin, but it can't distinguish between myoglobin, but I say that's all right. So in one of the studies that I read, what they did in order to get a blood flow curve was they had the subjects plantar flex and hold, and that allowed them to get a full hemodynamic curve that showed how oxygenated this limb was. So with these rigid obstructive sockets, because they're usually made from laminated carbon fiber and it's rigid and it's light, the problem is it's fully encapsulating the limb. This is on the mindset of a total surface bearing socket, or a TSB, that is the only way that an amputee can wear a socket, because this, there's one of the carbon fiber sockets there, and as you can see, there's the casting. Take the casting, and eventually we get here, and that takes about 2 months, because the person needs to be on their test socket for about 4 weeks. And then we have to do the modifications on that, and then a step beyond that, we have to actually pull this laminated carbon fiber one, and then we have to put it all back together, and then get you into the office. It's a long process. But with this carbon fiber structure, there's not room for the flesh to move around. There's not room for the muscles to contract or theoretically get more blood flow into this limb. So with that potential for limiting of the vascular remodeling in the leg, we've got another problem here of how do we get them up, moving around, and still have a prosthesis on that allows for their body to correct for these issues. Another issue is refitting of sockets, because fluid volume changes, and these sockets are $1,000 a piece. So unless you have really good insurance, or your prosthetist is really good at filling out the paperwork, you may not be able to get a new socket when you need one. And hence we see the problems just keep piling up here. Now, let's say you do have one that fits well. One of the big thoughts is proprioception. So just the ability to land that prosthesis well and maintain gait and still be able to, respond to changes in ground. Now, there are microprocessor feet, microprocessor knees, but one of the big things is it's going to have to come from the actual residual limb itself. And there's a lot of compensatory gait mechanics that occur during gait in an amputee. One of the studies that I looked through, there was high hip extension during early stance, so almost a braking bit with the leg, and then there was higher hip flexion during late stance as they're coming forward, well then they're trying to kind of pull in here. One of the other issues is that the prosthetic knee tends to carry the center of gravity in a different place in comparison with the normal knee, which an and as a result, the gravity line stays within the base of support during gait so that the risk of falls will not increase. And that was a study by Kohler, McNichols et al. But in other studies, what they have done to test for proprioception, and it's actually very simple, is the use of a goniometer. So what they'll do, either with the prosthesis on, or as you can see here, you could have somebody sitting. They did verify that that was a valid way of testing proprioception, and that they could sit down, and what you'll do is you tell the subject to, bring your leg up to 15 degrees, and then we use a goniometer to see how close they got to that, and closer the better. Here's how we fix all this, in my opinion. This is the Martin Bionics socketless socket. It's a modular socket. It's basically pieced together, and whereas I said that a traditional total surface bearing carbon fiber socket takes about 2 months to fit, maybe longer, this takes 3 hours. It's more open air to where the limb can actually breathe, because that's another complaint. One of the fluid volume problems is sweating, because there's no airflow to allow that leg to breathe. So you get fluid volume changes there, and then with that open air, we may be able to see that the muscles can activate more, that with that, greater vascular remodeling, which hopefully would limit these reamputations that subjects are having to go through. And as a common joke, other people have heard me talk about this. This right here is actually, this is for an above the knee amputee. And this right here is where they're going to weight bear. Now that goes on the ischial tuberosity, and usually this is a rigid carbon fiber shelf that is just resting on your tailbone, and every time you walk, that's where all your weight bearing goes. You actually, they tend to develop osteoporosis of the femur because there is no weight bearing. Now it's going to be the same here, but this is designed to be like a climbing harness. As we got to joking about in other classes, we call it a butt hammock. Jay Martin told me that his subjects or his patients will often lean onto their leg and rest in this hammock because it is so much more comfortable. Some of them either have on the sides where it's kind of grippy, or they have another hammock that goes down into down in there. So if you do piston or have the propensity to bottom out, you've got soft conforming fabric instead of hard carbon fiber. So hopefully we are limiting pistoning. We are encouraging hypertrophy of the muscles, encouraging vascular remodeling, and the sensory feedback from something like this, because it's set to fit like a sneaker. So we're addressing all these issues here, and one of the other ones is energy consumption during walking. Because for an average person, walking is not a challenge, but for somebody who doesn't have a leg, they've got to be able to get up and move around. It is hypothesized that the socketless socket will perform as well as, if not better, than a traditional laminated carbon fiber socket, and that the open air design, and adjustability will increase oxygen saturation, vascular remodeling, as well as hypertrophy of the muscles of the residual limb during exercise and at rest due to the lack of restriction against the skeletal muscles of the residual limb. The purpose of this research is to validate the Martin Bionics socketless socket as a valid prosthetic component. It is hypothesized that after wearing the Martin Bionics socketless socket for 4 weeks, the angular gait kinematics of the subjects will be the same or more symmetrical to their sound limbs. It is also hypothesized that those utilizing the socketless socket will show increased muscular hypertrophy as well as increased oxygen saturation in their residual limbs, as well as the same or reduced energy consumption when measured using a metabolic cart. So for my subjects, Between 2 to 5 subjects will be sourced from local prosthetics and orthotics offices here in Lexington, possibly the VA, but it will be limited to unilateral transfemoral amputees. Gender, age, and time since amputation will be recorded, but will not be a factor that is analyzed. Cause of amputation will not be a factor, but will be recorded. Subjects will need to have been using their prosthesis for at least 6 months. Any comorbidities will be recorded. Subjects will have healthy limbs lacking any blisters, sores, swelling, or pain. Subjects must be able to ambulate with only their prosthesis. No cane, no walker. Components of each prosthesis will be recorded, including the liner selection, and whether or not the subject utilizes passive or active suction, and it will be preferred that subjects are tested at the same time of day in order to offset any daily fluid volume changes, because it can change dramatically throughout a day. I met a guy once and he started with 3 socks, literal socks over his leg, inside his socket in the morning, and by the afternoon he had on 15. So big changes. Metrics such as age, gender, and time since amputation will be recorded, but will not be utilized as exclusionary principles. So, with the experimental pistoning methods, and this is just kind of a little basic idea here, since there is no definitive method for testing pistoning during dynamic loading or walking, I'm going to try something new. So what we're going to do, very simply, is markers on the socket, markers on the liner, and those will be analyzed using MATLAB, just to see if there is a big difference during heel strike and when they go through on swing phase after that. All right, methods. Informed consent will be obtained before entry into the study. Subjects will report to the laboratory and spend 15 to 20 minutes resting in the supine position without their prosthesis. Subjects will then be fitted with an O2 mask attached to a metabolic cart, where baseline O2 consumption will be recorded, as well as fitting of a chest strap heart rate monitor, where resting heart rate will be recorded. While the subjects are in the resting phase, a near-infrared spectroscopy probe will be used to scan the O2 saturation of their affected limb at 10 hertz. For transfemoral amputees, the muscles that are going to be scanned for NIRS, as well as EMG, are the vastus medialis, rectus femoris, vastus lateralis, biceps femoris, semitendinosus, semimembranosus, and gluteus medius. Following that NIRS protocol, subjects will continue lying supine while an exercise band is used to provide resistance during exercise loading of thigh flexion, allowing for a hemodynamic curve to be established at relative rest. Subjects will then be instructed to rest in the prone position. This process will be repeated for hip extension. During both of these protocols, a goniometer is going to be used to measure those proprioception angles, because they're going to be instructed to raise your leg to 15 degrees, 45 degrees, so on. In traditional fashion of being in a O&P laboratory, residual limb circumference is going to be measured in 2 centimeter longitudinal increments, so going up the leg, and this is to kind of see how how the fluid volume is behaving in their leg at that time of day. Subjects are going to be fitted with EMG on the same muscles that were scanned during NIRS, and those EMG electrodes are going to be inside their prosthetic liner. EMG is going to be collected at 1,000 hertz, born between the socket and liner, or between the liner and skin. After EMG has been fitted, subjects will be instructed to don their prosthesis. They'll be refitted with their O2 mask, and then they're going to be instructed to walk on a treadmill at a self-selected walking speed. Now, I'm expecting about 3 miles per hour, because that's an average person's walk speed, so we're going to count on just a little bit less, 2.5, 2.8. And then that's going to be recorded. We want them up there for about 15 minutes. And that's also on that treadmill, it's a 3% grade to simulate just normal ground walking out in the world. O2 consumption, treadmill speed, and heart rate are going to be recorded, and then we're going to use kinematic motion capture to measure the angular displacement, so hip flexion extension, knee, ankle flexion and extension. We're going to be using 15 cameras, a Cortex motion analysis software. And the markers are going to follow pretty close to Helen Hayes. They're going to be on the 5th and 1st metatarsal heads, lateral and medial malleolus, lateral and medial tibial epicondyles, and the anterior superior iliac crest, sacrum. Might do some out here on the posterior, the iliac crest or iliac spine. And then we're going to include Cleveland marker clusters on the thigh and shank on the lateral, as well as on the prosthesis, since they don't have, a foot or a tibia. These markers are going to be placed as close to the mechanical axis as well as on the prosthesis as well as the healthy limb. It's kind of standard process there, and then those experimental pistoning markers are going to be put on. So once gait analysis is complete, the subjects will be instructed to quickly seat themselves, doff their prosthesis, and then we're going to scan for that using that NIRS once again to get a post-exercise curve, and we're going to use the exercise band to kind of keep the heart rate going just a little bit. This takes about 2 minutes. Within 24 hours post-testing, a certified prosthetist is going to exchange their traditional socket for one of these socketless sockets, and we're going to change that at what's called the tech plate, and that's just the very bottom of the prosthesis, or of the socket there, so basically right here. So the idea is that no alignment should change in their prosthesis. The only thing that is supposed to change is the socket. I'm going to be very careful to make sure that that's the case. So they're going to get their new socketless socket. They're going to walk on it for 4 weeks. We're going to have them come back in and see what happens using the exact same protocol. Everything's going to be 100% the same, including the treadmill speed, and hopefully where we palpate the muscles. I'm going to try to take pictures of exactly where the EMG electrodes go. So statistical analysis will be performed using SPSS. We're going to use an ANOVA. I'm going to use an ANOVA to see, just do kind of a quick one between all of these variables. But the main thing is they're going to use a paired samples t-test from pre to post, because they're going to serve as their own controls. So the things that I'm going to be specifically testing with these t-tests to see if there's enough change: gait kinematics, O2 consumption, O2 saturation of the muscles, EMG muscular activation, proprioceptive angles, and limb circumference changes. If we get enough subjects, because prosthetic studies tend to be very small, averages will be created from the groups, and then we'll just do a paired samples t-test again. Hopefully this will account for or eliminate as much error as possible in the statistical analysis. So with the need for more dynamic sockets in our amputee population, as well as the need for a sustainable and easily adjustable socket for amputees in underdeveloped countries, because these people don't have access to a prosthetist. They don't have access to somebody being able to cast them. One of these can be fit in 3 hours, and there's a good chance that they could, if they took care of it, somebody in a third world country could use this for a long time. And even if they couldn't, it's still going to account for all of the other normal issues with a prosthesis that they just won't be able to work with where they're at. We reduce the fitting process, so we get somebody up and walking more soon. Hopefully stimulate vascular remodeling, and I think everybody feels pretty good when they get to get up and walk around on a nice sunny day. So hopefully we'll improve mental health in that way as well. And the last little note here, the healthcare costs for reamputation are astronomical. Did a little math here and adjusted from 1996, adjusted to today's money, $6.9 billion a year is spent on reamputation. Because it's not just Amy Purdy doing fancy skiing and somebody going rock climbing. I believe Kirstie Ennis is climbing Everest right now, and she's a Marine missing a leg. Well, it's somebody's grandmother. Wants to be able to get up and walk around. So with all the problems that the socketless socket has the potential to fix, I don't think it's been given enough credit in the prosthetics and orthotics world. And if I may offer my own opinion on this, it's because the prosthetists are going to lose money. And that's not what healthcare is about. It's about taking care of your patients. So hopefully we can provide a little bit of validation and help out a lot of people. Thank you very much.